Well, thank you so much, Professor Zeller. As always, you break it down so nicely for us, and I loved it because you really divided it by task classification. I wanted to ask you a quick question. Honestly, for myself, I've been very surprised. Sometimes I have a long 30-centimeter lesion and I pre-dilate. I mean, my mindset is that, oh my God, I'm going to have to stent, or this is going to be very difficult. And I pre-dilate and it looks reasonable, and I do DCB and the results come out nice. My question is that a lot of folks, and there's been a couple of studies, single center studies that have shown DCB plus BMS versus DES. What are your thoughts about that? Why not, angioplasty, DCB, see what it looks like, and then bail out with bare metal stent versus to go to DES? Do you have any preference with this?
Well, I have a clear preference, which is leaving nothing behind. Well, or as, yeah, or using tags or focal stent if necessary. So I have only a few indications where I implant a DS as a first-line strategy. Coming back to your question, we don't have data, unfortunately, yet available comparing drug-coated balloon with a bare metal stent implantation against DS. Those data are not available. But anyhow, my strategy, and coming back to your case, is definitely DCB if the vessel is responsive, and if at the end after DCB there is still recoil or dissection, if it's longer, then I implant a stent. If it's a short area, I use a tag. But we have no data to prove that this is equivalent or even better as compared to DES.
Great. Thanks so much, Dr. Zeller. Lawrence, if you can put yourself on mute, I would really appreciate it. There's some background noise. I was going to go to Dr. Hart. Karen, we have had some challenges with the DCB with safety. And Professor Zeller nicely showed the data that he had shown. There's a lot of data out there regarding safety. Collectively, they have been shown that over time, as we have more patients that have been followed and more data, it seems like we are getting more and more stable with the safety concerns. Has that impacted your practice, and what are you doing to deal with this safety issue?
Thanks, Mehdi, for the question. So as of now, it hasn't really changed my practice as with regards to my selection of use of DCB. I have different kinds of discussions with my patients regarding safety and the data and the current research looking at safety. I think one of the things our group has done very nicely is looked at our own data. So we haven't actually confirmed data to support increased mortality with drug-coated balloon angioplasty, and actually are finding that in certain groups, particularly high groups like our CLI patients, there might be benefit. So those are the things we're doing from our end, is really looking at our own data.
That's great. Peter, you do a lot of complex work. What is your approach in regards to DCB and DES and, let's say, popliteal, heavily calcified popliteal lesions and those kind of things? I guess what I'm asking, how do you deal with the utilization of interwoven stent versus drug-eluting stent and DCB? How do you manage that in those complex popliteal calcified lesions?
Yeah, it's an excellent question, Mehdi. I think that for these distal SFA and popliteal lesions, we all know that the hazards of standard laser cut nitinol stents. And certainly in our practice, particularly if it's calcified, we'll usually employ a strategy of prepping the vessel with intravascular lithotripsy. And similar to what Dr. Zeller mentioned a moment ago, if we get a nice full expansion with the lithotripsy balloon, no significant dissections or recoil, we'll go ahead and treat that with a DCB. But if that's if that doesn't work and we have to resort to a stent, then I think the Supera really fits the bill very nicely. So we typically will specifically and preferentially use Supera for these distal SFA and behind and above knee. So anything involving the popliteal or distal SFA, if it's very heavily calcified and it needs a stent, then we typically will go with Supera. I mean, the data with Alluvia is very good, but we don't really have a great sense as to how it performs specifically behind the knee. And once those data become available, that potentially may change my own personal treatment algorithm. But for right now, until we see data that does not show an increased risk of stent fracture or restenosis for alluvia in that particular location, I think we're still using Supera, particularly if we've had an opportunity to prep the vessel well with intravascular lithotripsy and put some drug-coated balloons down prior to implantation of the stent.
Wonderful. Rob, let me come to you. You know, you deal with a lot of supply chain issues and cost issues related to this. And there is parallel to this, there is this concern about heavy calcification and absorption of the drug. Does that play a factor for you? I mean, there are all kinds of data.
Yeah, it's a great question. I wish I could give you a very, very simple answer. Peter very eloquently said that we've got a lot of challenges dealing with these complex lesions. Do you, try DCB? Do you try debulking? Do you try an interwoven stent? Those are 3 different technologies. It's not clear you're going to get reimbursed for every single adjunctive thing that you do. Is a single DES strategy more attractive? I can tell you from supply chain, it's more attractive. But is it going to lead to better outcomes? I don't think we have a definitive answer yet. And so I think all of us are struggling to generate more data around these complex lesions. Mehdi, you alluded to this in the previous section, no pun intended, but we don't really see a corresponding increase in reimbursement to offset the heavy supply costs for complex lesions. So somebody could treat a task A lesion with atherectomy stent and get paid the exact same amount of money, or the institution would get paid the exact same amount of money for treating a task D or E lesion. And so that really does create challenges. I think from if I were to put a purely supply chain hat on, I would say I would want a single technology that has the most durable result and is the most reliable. But I'm a realist, and I realize that the complexities that we see in the femoral popliteal segment don't allow a single technology strategy. So I think we all want better data, and we all need to collaborate together to hopefully move in that direction.
That's frustrating. I agree with you. The fact that doing a type A versus a type E, as you said, I think we need to extend the task classification to E. Lawrence, I was going to ask you: do you ever DCB and then place? We're talking about supply chain, but just for a moment, do you ever put a DES after doing DCB? I mean, is there a harm, or is it just a cost issue? I mean, we don't have data regarding any of these kind of approaches.
There's the anecdotes that we hear from Europe, from Tomas and from the Leipzig group suggest that they have done it in the past with little downstream effect. But I don't know that you gain a lot. So in my practice, to wear the supply chain hat or my boss's hat, we try not to overwhelm the cost per case. So we generally do it. There may be similar outcome as Tomas has shown. DCB with a TAP, or DCB with Supera, that may get you the best overall kind of combination paid C, which may be useful, but it doesn't overwhelm in regards to the cost.
Matt, in regards to antiplatelet therapy, does it change your antiplatelet therapy regimen when you're going with drug elution, DCB, DES, versus, let's say, if you were putting a bare metal stent? Does that impact your antiplatelet therapy and the duration?
I have to say, I think we're still trying to learn more about Alluvia, in particular, being a stent-based platform with drug-eluting technology. I think I feel fairly safe with the drug-eluting balloons and stopping dual antiplatelet therapy at a month. But I think there's a lot of interesting antiplatelet questions in general about the role of aspirin, and certainly we're learning some of the potential harmful effects of long-term aspirin over P2Y12 antagonism and in the PCI space. And I think some of those lessons may translate over to our population with PAD, which is a very high secondary cardiovascular risk, and may continue to evolve as
Manish, are you guys considering Compass and Voyager in some of these patients, claudicants, especially Voyager now, with especially if you're putting drug elution, the platform? Does that impact you, or is that relevant?
Thanks, Mehdi. And I think I'm going to have an antithrombotic talk where I'll go through that, but I'll just sort of preview that by saying that I think our practice for post-revascularization antithrombotic therapy is going to change and should change pretty quickly over the next few years. I'll just say that our experience, and you'll see from Voyager, you'll see some DCB or let's say drug-coated products evaluation coming out that subgroup, and you'll see others. So my feeling is that if you want to use DAPT, you're probably going to use it for a short period and move to antithrombotic therapy long-term for sure.